Good morning, everyone, and welcome to today's Council on Black Health webinar entitled, What Can Implementation Research Tell Us About Equitable Interventions for Diabetes and Related Chronic Disease Prevention in Community Settings, a review of lessons learned. Today's presentation is part of the 2020 and 2021 webinar series offered by the Council's Solutions to Diabetes and Black Americans Core. This core is part of the NIH-funded Center for Diabetes Translation Research at the Washington University in St. Louis. The Solutions to Diabetes and Black Americans Core provides methodological and content expertise to advance the field of diabetes research in Black Americans. Thank you for joining us. My name is Tiffany Eaton. I'm a doctoral candidate and graduate research fellow at the Dornsife School of Public Health at Drexel University, where the council is based, currently working with Dr. Shariki Kumanyika, the founding chair of the council. I will be your moderator today. The Council's mission is to develop and promote solutions that achieve healthy Black communities. We leverage the credibility and perspectives of Black American researchers, other collaborators, and research partners to facilitate relevant, community-engaged, actionable strategies that positively impact Black communities. I would also like to briefly announce that the Center for Diabetes Translation Research is now accepting applications for small pilot projects until February 23rd, and I will post the link with more information in the chat momentarily. Today's webinar will discuss implementation research in community settings and highlight lessons learned to guide future research and practice in diverse settings and geographies. During the presentation, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees. Today's presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. Our presenter this morning is Dr. Stephanie Mazuka. Dr. Mazuka is an assistant professor at Washington University in St. Louis. Her research seeks to develop and evaluate evidence-based approaches for promoting healthy eating and physical activity to prevent chronic diseases such as obesity, diabetes, and cancer. This research is mainly focused on improving home environments and organizations, such as public health departments, child care centers, and community-based groups to support healthy behaviors for those with higher risks of chronic diseases. Additionally, Dr. Mazuka is interested in studying the dissemination and implementation of evidence-based programs and policies into public health and clinical settings to improve the translation of research into practice and ultimately improve individuals' health. Dr. Mazuka, I now invite you to proceed.
Great. Thank you so much, Tiffany. Let me just grab control of the slides here. And just like the magic of Zoom, it works. Fantastic. I want to thank Tiffany and Shariki for inviting me and coordinating all of the logistics. I'm feeling really energized by having a chance to reflect on this research and present the lessons learned and some opportunities for future work with you all today. And I'm looking forward to some great conversation at the end of the session today. I'm going to move through the slides fairly quickly. I have a lot to cover, but I'm going to try to do it in as short of a time as I can to leave time at the end for questions. And today I'll be sharing with you a brief overview of implementation research, then going through some of the evidence from implementation research outside of clinical settings, synthesize some common challenges, and highlight lessons learned for future research. Much of this work is based on a forthcoming paper in annual reviews that I had the opportunity to work with a stellar group of co-authors on. Many thanks to them for their hard work and for teaching me so much about this type of research, as well as my funding, the CDTR, as Tiffany mentioned, the Prevention Research Center, and the Implementation Science Center for Cancer Control, all based out of WashU, which provided me the opportunity to spend a lot of time reading and synthesizing this work. The paper is in the final stages of production and should be online fairly soon, so keep an eye out for it. Not to dwell on this too much, but I did just want to remind us that the burden of chronic diseases is high, and its effects are felt on individuals, healthcare systems, and communities. They affect nearly 2/3 of Americans at some point in their life. They cause the majority of diseases globally and cost us a lot of money. about $3.6 trillion annually as the most recent estimate I could find. We're seeing the effects of chronic diseases like these on the slide, not just in terms of these as ends in of themselves, but also as they relate to newer emerging diseases like the link between these and COVID-19. So we really need to focus on preventing and treating these diseases quickly. We have made some progress. So for example, with smoking, but we know that it's not enough and it's not equal. So we need a continued focus on prevention, especially for those at most risk of these diseases. The lack of progress isn't due to just a lack of evidence-based approaches. So there's been a focus not just on generating evidence about the efficacy and effectiveness of programs, but also how we get these programs into real-world settings. This is known as implementation research among a lot of other terms. I'll use this and D&I for dissemination and implementation research pretty interchangeably throughout the presentation. I've provided the NIH definition, which is a favorite of mine. And what I like to point out here is that in D&I research, we're focused on what needs to be done, what we call implementation strategies, so that people, organizations, and communities can effectively implement an evidence-based program. Outcomes of this type of research typically evaluate how much, how well, and how quickly programs and policies are implemented. Key to research is the acknowledgement that there are multiple levels of context, so at the individual, provider, organization, community, and kind of broader external factor levels, and that contextual factors and the social determinants of health can influence implementation and intervention effectiveness. I like that D&I takes kind of a wider lens to understand context, so really taking a holistic approach to understand what affects health-related programming. There's a focus on external validity, so how are the results from a study generalizable to other settings, populations, and context? And the last two are somewhat related, but there's a premium placed on the perspectives of stakeholders and partnerships with organizations that are actually the ones who are implementing your evidence-based program or policy. Determining and incorporating their perspectives into your D&I strategies is critical to their success, as is developing strong, lasting partnerships with implementing organizations that can carry your research outside of the research context. And I could spend a lot of time on this because I'm a nerd, but I just want to point out here that D&I research is related to, but distinct from efficacy and effectiveness research. And I think this visual is really good to show that. So we're focused here on not just does a program work, but how it works, making a program work in real world practice. There's often an overlap of these sorts of research questions in one study. So it's not that it's always this clear cut and an individual within different studies, but I think it's helpful to lay them out as separate ideas. Also, I want to point out that you don't have to wait until the end of an effectiveness study to think about its dissemination and implementation in the real. You can actually be building in strategies and an understanding of the real world context that would promote dissemination and implementation, even at the efficacy stage. A couple more thoughts about involving stakeholders and thinking about partnerships with organizations. Incredibly important, but it's not without challenges, especially when we're trying to reach populations that are socially disadvantaged. We have to take into account the social class and power gradients, and in many cases, the racial and ethnic differences between researchers and the populations to be reached. That said, involving stakeholders can help researchers learn about and understand aspects of the organizational context and obtain meaningful input for those who are insiders with a deep knowledge of the context of their community and their organization. Additionally, stakeholder input and buy-in are critical in implementation research, as stakeholders like community leaders can communicate about the benefits of an evidence-based program in a way that promotes the individual's willingness to engage with it. To date, much of the implementation research that has been conducted has taken place in health industry settings like hospitals or medical or public health clinics, which is understandable when you think about things like HPV vaccination or early detection of cancers. So their missions and revenue streams are exactly for health services. But this may neglect the opportunities for implementation research on programs and policies that can be delivered in the many other settings that are important complements to these clinical settings. Implementation in what I'll refer to as community settings is challenging because it involves organizations for which primary missions, capacity, cultures, and value, even when they're compatible with health goals, don't necessarily prioritize them or can't prioritize them, or they might not have internal or external accountability for health outcomes. So we focus here on implementation research to understand how to best integrate health-related programs and policies into organizations that are not necessarily designed from the start for health-related programming. And this is the figure that I'll use to kind of anchor the talk. The settings that we focused on for the review are the 6 broad categories you see in the circle. I'll walk through each of them individually throughout the presentation. And for this, we focused mainly on evidence generated by reviews to get kind of a high-level view of the state of the literature, but I'll share some individual studies as well. This also, because we focused on reviews, means that there's a lot of emerging literature that was not necessarily directly incorporated into the review. So know that this is kind of a really growing area of research. These community settings are valuable for health promotion for many reasons. They influence the everyday lives of individuals. They often have frequent and long-lasting contact with the individuals they served. They serve relative to health settings. And what we think about these as kind of the authentic context that ultimately shape people's lives, from everything, including basic survival needs, to their health behaviors, to their social interactions. So they're the settings of daily life. These settings are one part of a larger context that can affect the implementation of programs. So that's why we have the context and health equity boxes on the outside. From a health equity perspective, it's important to work with these settings because they play a major role in reaching the populations who have disproportionate chronic and infectious disease risk, precisely because of the systemic societal factors that make things like access to basic survival needs and health improvement opportunities inequitable. So first I'll start with faith-based organizations, which have many advantages in terms of chronic disease prevention. One of the unique characteristics of this setting is the potential alignment with religious doctrines. So this might encourage members of faith-based organizations to participate in these sorts of health-focused programs. A challenge is that they can be sort of tight-knit. They can be wary of outsiders, either because of their social structure or because of their historical experience with researchers. So you have to keep this in mind when you're approaching new and developing these relationships with churches. Much of the work here initially was done in Black Christian churches. So if we think about kind of the foundational intervention here is the Body and Soul program, an evidence-based fruit and vegetable intervention that's been disseminated across the United States. And more recent implementation work has focused on Latino and Filipino Christian churches, as well as Islamic religious settings. One of the implementation examples in faith-based organizations is Project HEAL, which combined previously tested interventions to promote screening for breast, prostate, and colorectal cancer in Black congregations. The model, as is typical among faith-based interventions, uses a community health worker model for delivering the intervention. So in Project HEAL, these community health workers lead the church through the intervention, which contains a series of 3 workshops for church members focused on improving knowledge of and access to and engagement with screening practices. One of the key issues with the community health worker model is how to provide adequate training and ongoing support for them, because these are folks who don't necessarily have a health background or health expertise. So this team, led by researchers at the University of Maryland, used a cluster randomized trial with 15 churches to test 2 different approaches or implementation strategies to train community health workers to implement the program. One was a traditional approach that used in-person group-based training and high amounts of ongoing technical assistance from the research team. And the other was a technology-based training. So thinking about this as self-paced and asynchronous, something that we've become familiar with in the last year. And they provided very little technical assistance to that group. They found increases in overall screening rates, especially with the colorectal cancer screening. So they had a positive outcome there, but there were few differences between these 2 types of implementation strategies. Similarly, community health workers in both arms of the study showed similar increases in their knowledge of and ability to lead the intervention. So this shows that a low touch, less resource intensive training model might be a promising approach to guide implementation. And future research efforts will focus on kind of teasing out the difference between these 2 and scaling them up into larger and more diverse settings. The next is educational settings. This includes everything from early care and education settings all the way up through institutes of higher education. In these settings, we have children and young adults who, if you can remember a time outside of the last year, is where they spend a lot of their time. This offers many opportunities to influence health behaviors across multiple levels that can have benefits beyond physical health, including an emerging evidence about their link with academic-related outcomes. However, since the main focus of these settings is education, it can be tough to get staff to implement voluntary programs that have distal health outcomes while they're trying to focus on the many academic objectives that they're juggling throughout the day. The programs and policies that have been implemented to date typically include some sort of child-focused, behaviorally based education materials, programs delivered within classrooms, policies related to meal service and wellness, and some have activities that are teacher or parent facing, some outreach and educational meetings, as well as changes to the physical environment that are supported by small incentives or grants. And a really interesting example of implementation in educational settings is the Action Schools British Columbia program. This comprehensive school-based intervention was designed to modify school environments to improve opportunities for healthy eating and physical activity by facilitating changes at the school, staff, and child level, as well as to facilitate a supportive community and provincial level environment to disseminate these types of programs. So just to give you a feel for what the program looks like, the physical activity portion of the program and a school-specific planning process where the local stakeholders, so teachers, administrators, and parents, assess their current physical activity promotion practices and environments, and then create specific plans to make improvements. Also, teachers are asked to implement daily physical activities in their classroom using curriculum and equipment resources provided. At the provincial level, they engaged with key education, health, and nonprofit stakeholders to guide not only the development, but the implementation and evaluation of this model. So they engaged upstream stakeholders from the beginning. And in doing so, they began their efficacy trials with a for scale up in mind and generated evidence so that provincial level decision makers could understand the benefits of the program and be more amenable to disseminating it. An initial evaluation of the program in 10 schools demonstrated that it was effective for increasing physical activity and other health outcomes. And after this, the British Columbia government funded the dissemination of the program through various marketing campaigns and other strategies, and as well funded the evaluation. After the program had been disseminated for several years, they examined some of the contextual factors that were associated with the implementation of the intervention by surveying schools and staff that had implemented the program across about 4 years. Of the many constructs that they measured, they found, here you can see with the red arrows, that the opinions about the intervention's attributes, so whether it was a good fit within their school, the self-efficacy of teachers, and the organizational capacity were related to implementation in the direction that you'd expect. So higher self-efficacy, better implementation. And I like this example because it's a really a clear example of why it's important to form partnerships with key stakeholders from the beginning of a project. They've been able to do incredible things over several decades, I think in large part because they positioned themselves really well within the community. Additionally, social service organizations can be important for implementing health-related programs. And these are a diverse group of settings, including those that are focused on housing, unemployment, child well-being, so things like adoption, child protection, and child development, programs that support refugees and undocumented immigrants, and the infrastructures that support these programs, like the network of 211 organizations across the US that provide referral to these organizations. Sort of similar to educational settings, their focus is not often on physical health, so it may be difficult for these organizations to prioritize chronic prevention. That said, there's an emerging evidence related to programs focused on these different lifestyle behaviors emerging within these organizations. One of the biggest takeaways I had from reading about this work in these settings is that because they're so diverse, there are a lot of opportunities within these types of organizations to integrate different types of health-related programming, but it should be matched to the operational characteristics of the organizations. So this is their usual interactions with individuals, their reporting and quality control mechanisms, and their financial and other reward systems. So thinking about the interactions with individuals, you can think about the differences you might expect in the types of programs that you would implement in an organization that only interacts with individuals once for a short period of time, compared to those that foster ongoing long-term relationships with the individuals they serve. And I'm going to somewhat embarrass Dr. Rachel Tabak, who I believe is on the line, and highlight an example from her work along with Dr. Hare Joshua. This is a wonderful example. It's the health study. The current ongoing trial is the health D&I study. And Dr. Hare Joshua has been partnering with parents as teachers for decades. This is a national home visiting organization for young children and families. Their foundational curriculum is focused on several content areas related to child development, parent-child interactions and parenting behaviors, focusing on a development-centered parenting strategy and family well-being. It leverages the strengths of a family to further promote child development, so it really focuses on the assets and strengths of a family. During initial studies, the team developed a health curriculum modified from the diabetes prevention program to improve moms' healthy eating and physical activity behaviors and the home environment related to eating and physical activity. To make the health content feasible to deliver and sustainable within the PAT model, it was designed to fit within the existing family well-being component of the home visit, so within the time-limited visit that they were already doing. Embedding health in this way enables participation from mothers and families. The organization already provides the home visiting services, and delivering through this model overcomes some of the barriers to participation that mothers may face in terms of being able to participate in-person group-based trainings, and it leverages their already existing interest in developing their children, so the benefits to their children. In the effectiveness trial, they found that embedding the health curriculum led to a difference of about 10 pounds compared to moms who received the standard PAT approach, which is remarkable. And currently there's an implementation trial focused on understanding the effectiveness of the program in a wider population and the implementation by training the parent educators by the national PAT staff, so their usual training mechanism, and they'll measure determinants at the PAT, the parent educator, and the mother level. Next is city planning and transportation, which perhaps should also include municipal governments and other departments within governments outside of public health. Many of the examples we found focused on multi-sectoral partnerships across local governments. But thinking specifically about city planning and transportation, we know the links between planning and transportation efforts, the built environment, and health. This setting has some real potential for long-lasting structural changes that can work towards health equity. For example, safe and affordable transportation routes that offer access to jobs and services that enhance health are needed in low-income communities, and city planning efforts can help with that. Around the globe, city planners and transportation practitioners and municipal governments have been called on to support chronic disease prevention in a way that is quite transformative. So initiatives like the Health and All Policies efforts that have been picked up across the globe highlight the need to consider the health implications of all governmental decisions, at minimum having no benefit or no impact on health, and at best having a positive impact on health. Thinking about the city planner's role in this, there were some really interesting papers that discussed how city planners were reconceptualizing their role. So in the UK, they had to move from thinking about prioritizing the development of dense housing areas that maximized profit to prioritizing those that had access to public transportation and that were more livable, sustainable communities. So it's been interesting to see these city planners take on a different role, maybe one that was more linked to their original goal as a field, but kind of returning back to that. Another important lesson for this setting is the focus on generating data for policymakers. So assessing things like cost and other locally contextualized information that we don't always capture in our research can be really important to the success of our implementation efforts. And a great example of implementing a program with the help of many organizations within a community, thinking largely about city planners and transportation folks, are ciclovías, also called open streets. These are events where streets are closed to motor vehicles and exclusively used for non-motor transport and walking. They have benefits, of course, for leisure physical activity promotion, but also for other things like decreasing unequal access to recreational opportunities, promoting social capital, improving quality of life. They have environmental benefits, thinking about reducing particulate pollution and street noise, and can increase business activity. The picture on the left is kind of one of the original models in Bogota in Colombia. And then you can see on the right is an example in New York City, which I like that example because you can see that it's not just about promoting cycling. It generates a lot of foot traffic as well. They've been picked up all over the globe and including rural communities as well. I just couldn't find a good picture of that for this presentation today. The scale up of these ciclovías has happened largely outside of research studies, but they have been studied over the years. Similar to the Action Schools example, some researchers in Colombia, led by Dr. Sarmiento, conducted a mixed methods evaluation of the sustained implementation of ciclovías across Latin America to understand how much they had been implemented and what contributed to their continued implementation. All of the programs they evaluated shared some degree of the factors that I've grouped here in terms of the individual, organizational, and external levels, even though they differed in characteristics like who funded the program at a given time. They showed a lot of heterogeneity in terms of the factors that contributed to sustainability, so kind of the balance between these different factors. And the researchers pointed out here that both the heterogeneity and the flexibility in the design of these ciclovías likely contributed to its success. So it allowed these communities to adjust to changes in these contextual factors over time. So when there were political changes that reduced government support, some of these groups had to take on more of an active role in implementation, so then relying on things like organizational capacity and alliances more heavily for at least a short period of time. And I think this example is a really good one because it helps us think about the interrelatedness of these factors and calls on us as researchers to understand how we can support sustainability of programs and policies. Chronic disease prevention can also happen in workplaces, which I think about as somewhat similar to the education setting in terms of where adults spend most of their time, again, at least for many of us in non-COVID times. The health of an organization's workforce is important not just for those interested in health in and of itself, but also as it relates to things like healthcare costs and productivity. Some of the implementation strategies that have been used in previous research are things like informational meetings, program champions, wellness committees, and several other things. These programs can be anything from kind of a one-time health screening on-site to more ongoing behavior change programs, or things like, wide-scale environmental changes to promote health. And one of the key pieces from this area of research is acknowledging that smaller organizations and those in certain industries like retail have been underrepresented to date. The contrast I think about here is with large companies that either have several dedicated positions for wellness or that contract out with really expensive outside vendors for workplace health initiatives, which are not going to fit within smaller, leaner operations. So one example of work that's been done within small and low-wage work sites is the Health Links study conducted by researchers in Washington. And they focused here on implementing evidence-based interventions for healthy eating, physical activity, tobacco cessation, and cancer screening. They did this work in work sites that had between 20 and 200 employees so that they could specifically address the barriers of time, accessibility, and resources that had come up in their prior work specific to these small work sites. The intervention itself is kind of a multi-phase process by which the employees and the employers assess the current worksite health promotion practices, and then they receive tailored recommendations for programs that come from the community guide, and then provide implementation support for initial implementation and maintenance of these programs. They tested this program with just this Health Links model alone, an arm where they added this plus a wellness committee, and then compared it to a delayed control arm. The primary outcome was the extent to which implementation or interventions were implemented on a scale from 0 to 100%. And across the 2-year study, the worksites received lots of different support, especially within the first months of the study. So that's kind of the immediate post-intervention and implementation measure that's in the middle there. The focus, I think, which was really nice here, is that they provided toolkits to the employees and the employers to make the implementation of these programs as turnkey as possible, standardize the approach across different sites. They showed that there was an increase in the implementation of recommended programs in both of the active intervention and implementation groups, but not a difference between the two. And one thing I found interesting from this study is that only about half of the work sites that were assigned wellness committee arm actually sustained a wellness committee across the 2-year study. So we'll really need to understand what about wellness committees is important and how they can be implemented and sustained over time. Regardless, this work is important for promoting health in these small and low-wage work sites that face unique challenges. For lack of a nicer term for this group, this was kind of our other group. I think about this as almost like the community-based organizations, like the smaller, mostly often volunteer-led organizations. So these are settings that focus on different aspects of youth or community development, a lot in YMCAs, Boy Scouts, all of the out-of-school programs fall into this category, and sports and recreation programs. They have wide reach because of their popularity in the everyday life of individuals. And I think one of the things that's interesting about this bucket of settings is the influence of social networks. So embedding things like a weight loss program in a recreational program that men participate in to play soccer or football in the UK is an interesting way to kind of leverage some additional health interventions benefit in what an activity that people would already be doing. We have some growing evidence about implementation in these settings, but it's definitely emerging, and I think there's lots of opportunity for growth here. But again, the heterogeneity of these settings is potentially interesting. So thinking about an example in this setting or in this group of settings about those that provide out-of-school experiences for children, we think about the Healthy Kids Out-of-School study that was focused on improving healthy eating and physical activity within the Boy Scouts of America and 4-H clubs. So there are voluntary healthy eating and physical activity standards for out-of-school settings. They've been widely adopted across the country, thinking about things like after-school care, but they're a little bit different when you think about implementing these in volunteer-led programs. So this group designed some intervention strategies and dissemination strategies to pair with them to integrate the principles of drinking right, moving more, and snacking smart within the Boy Scouts and 4-H clubs. The principles were simple, clear, and actionable, so making it pretty easy to implement. They had hands-on interactive trainings held during regularly scheduled program leader meetings at district and county, so higher up levels. And the local program leaders, so the troop leader and things like that, were given supporting materials, water bottles, snack recipes, educational activities, and some technical assistance to make changes. So they were, and I think one of the other interesting things about this program is that they incentivized the kids to participate in these sorts of changes by giving them a badge or a pin, so something that they would already be familiar with in the context of these groups. They, Dr. Economos and colleagues conducted a quasi-experimental study to evaluate the dissemination and implementation of these standards, reaching just about 85,000 children. So I think that the power of that is notable to me. They had success at the 6 to 8 month mark that they were interested in looking at in terms of the beverage and the move more standards. And these seemed to be easier to implement because they were either cost neutral or cost negative. And they considered another indicator of implementation success the fact that these program materials were integrated onto the Boy Scouts and 4-H websites, so seeing that buy-in from top leadership. They acknowledged some barriers like parent pushback and the cost and time, weather and space, kind of our typical barriers to healthy eating and physical activity, but they are working to roll this program out more widely. So I know I kind of gave you a really broad landscape of lots of different types of research, but that was kind of almost the point to highlight that there are so many opportunities to implement health-focused programs in the settings of individuals' daily lives. And I think one of the things that I found interesting was that each bucket of literature tells us something unique about implementation. So thinking about the training, health worker aspect in faith-based organizations, matching the program and policy with the organization, as we saw in the health study, and then thinking about kind of the changing context with the city and regional planning example with the ciclovias. So kind of just reiterating these lessons over and over. And another one of the things that I thought was interesting was that there are different ways of getting to the same end. So there were examples of just standalone interventions that were implemented in these organizations. There were some where it was just integrated into existing programming and policies, and some where it really took, a whole community-wide initiative to implement this a program or policy. So we have lots of options. In terms of moving forward, both with working with community organizations and for future research, of course, engaging stakeholders can improve our implementation efforts. And it's really important to build these partnerships on trust and for us as researchers to articulate the benefit of our research to community organizations. So we have to make the case to them as to why they should partner with us, creating sort of a demand for implementation for these programs. It's asking a lot of them, so we have to acknowledge that. And then thinking about really taking the views of the stakeholders and their opinions about the context, directly informing our implementation efforts. So not just acknowledging them and getting a check mark, but actually using that information in our research. In terms of the implications for future research, some of these follow directly from what I presented, and some of them were kind of just overall lessons learned. We need to continue to build out the evidence base for the programs and policies and the implementation strategies. It's not always a good assumption that an evidence-based program is evidence-based in all settings and all places. So we need to be really careful about what we're considering as evidence-based, making sure that it's appropriate for the populations we're working with. And then just continuing to build out the implementation strategies evidence. And the second point here, I think, is really important to think about. And I know there are so many people who have been doing wonderful work in this area, but taking an equity-focused implementation research perspective. So I think about here applying the health equity lens, as Shriki talks about in her Getting to Equity framework, not just acknowledging that the context and that there are inequities, documenting them, acknowledging them, but really moving us to understanding how we can address them and progress towards health equity. And in case you needed a reminder of what that great framework looks like, this, among others, I think is really setting the path for us to make strong progress towards health equity. Sort of related to this, I think we need to spend some time broadening our measures of context. So not just thinking about individual and organization level characteristics that can impact, that are more proximally related to intervention and implementation success, but also thinking kind of more broadly about things that impact health inequities. So pulling from other fields to inform our measures and understanding of the broad context. And then providing our decision makers with outcomes and pieces of information about our research that they can use. So things like cost and cost effectiveness are really important. And then starting to unpack how implementation is happening. So not just that this is our implementation strategy, but understanding the complex process by which implementation happens. With that, I will thank you for your time and attention. You can find us on the web, on Twitter, and by email. I'm happy to hear your thoughts and to answer any questions you might have. And with that, I will toss it back to Tiffany.
Thank you, Dr. Mazuka. And so what I wanted to do first was share the link to your paper in the chat.
Oh, great.
For folks to get that information and to follow that link. So we would now like to invite our participants to post questions using the Q&A button in the Zoom webinar interface. I see we already have a question. One attendee says, what an informative talk, thank you. Could you recommend any measures or assessments of organizational operational characteristics that can be used to decide which EBPP should be prioritized?
That is a great question. I can't think of any off the top of my head, but I'm going to write that down and give it some more thought. Some of them there are a couple, but I'm drawing a huge blank, and I can regroup and pass that along if that's okay.
Yeah, absolutely. We have another question. Can you talk more about the role of resources added to facilitate implementation and whether sustainability of such resources is typically taken into account?
Yeah, that's a great question. Man, I could probably spend a whole nother hour talking about that, but I think it is. There's a really interesting tension, I think, there between, in research we want to pay people enough to participate and acknowledge that they're spending their time and efforts, and that these programs need costs associated, or costs to kind of make them happen, but at the same time that has to fit within kind of the normal funding structure of their operations if they're likely to be sustained outside of our research initiatives. I don't think that we have a good solution for that now, but I have seen it seems like there's some movement in different spaces to kind of figure out how, well, I guess how different things can be paid for as part of their normal operating structures. So I think like with Rachel's example with health, that is now a program that can be embedded into PAT, and it won't necessarily cost them a ton more to train parent educators on that program. Rachel, you can correct me if I'm wrong about that, but the idea is that it's kind of a low cost add-on for quite a lot of benefit. But I don't think we have good solutions for that now, and it definitely deserves more attention.
Yeah. And so what is the relationship between strategic science and implementation science?
Oh, I have never heard that term before. It's funny, there's kind of like, a million different terms for implementation science, but strategic science is not one that I have heard of. I wonder if it comes out of like an organizational behavior perspective. But having never heard it before, I'm hesitant to venture a guess.
Okay, so maybe if that attendee, if you can clarify your question, and then we'll ask it again. But we also do have another question. Is good implementation always associated with larger outcomes? Is effectiveness always assessed to assure this?
Oh, that's a very interesting question. Okay, so I don't think that necessarily effectiveness is always measured in all D&I studies. At some point, you can kind of make the case that you don't need to go all the way out to effectiveness, and so you can prioritize more of the D&I research questions. My guess is that probably not, because there may be unmeasured contextual factors that have, kind of throw a wrench into your implementation efforts. I would think like any sort of study that's been taking place in the last year, you could have the best implementation strategy in the world, but you probably didn't predict a global pandemic. So I don't think that it's always the case, but on the whole, you would think that more quality implementation would lead to better implementation and thereby better effectiveness. But that's, I think, assuming a lot of things, like that you have the right program or policy, and that you've accounted for kind of all the different things going on within an organization.
Right. So we do have a bit of clarification. So for strategic science relating to basing the study on questions generated by potential users, it could be relevant to implementation research. For what, like an example, what EBPP is chosen for.
Yeah, so that is ringing bells for me in terms of what I have seen referred to as pragmatic research, generating knowledge that's useful, like back to the organization itself. And I do see a lot of overlap. It's not always the case where they're, like the Venn diagram is completely overlapping, but I do think that there are major advantages of considering that type of approach, because you want the organization to take ownership over these programs and policies. So if they're not bought in from the beginning, if you kind of come in with your like binder of an intervention and that's not what they want, then that's not very pragmatic or strategic and not going to do them a lot of good. So I think, yeah, focusing on generating evidence that's locally appropriate within an organization is important. And I think that concept does seem overlapped with implementation research. People really split hairs about these sorts of things, but I like to find their overlap and their like synergistic benefit for my own work and not the details so much.
Right. And so thank you for that. It's just a matter of, I see there's a link in the chat also shared, and I'll share that with you. I'm not sure if you have access to see the chat. And so again, just to remind attendees, if you have any questions, post them in the Q&A interface, or you can feel free to post them in the chat, as some already are, which is perfectly fine. But you mentioned, and sorry if you touched on this, but you mentioned some of the, the building the case and getting buy-in. Did you in your review see any challenges with that and engaging and getting that buy-in from some of the community and alternate settings?
I think there were undertones of it. These research papers are written kind of like after everything's done, and they're telling, like you want to put your best foot forward and not dwell too much on the challenges. But they're definitely real. I think one of the things that is kind of most evident of that is how many you have to reach out to get X number into your actual study. So that shows me that that the case wasn't quite clear enough to enough people if you have kind of like a low recruitment rate. But it seemed to me that the real successes were when people were afforded the time and space to develop these partnerships. And that's not always compatible with kind of like our typical academic model. So I think there are lots of challenges that I didn't even get to touch on today. But I think as organizations and academic institutions start to understand the importance of and how much time it takes to form partnerships to do work that has real public health and community impact, that those kind of, we can build in space for those challenges and build in resources to support researchers. I guess one of the other things that comes up about that is, I'm not really trained as a researcher to be like a communications and marketing specialist. So it kind of pulls from some other skill sets that we might not be trained to do in doctoral programs.
Right. And so just in thinking about this research, is it possible to get research like this funded? Any experience with this?
That is a great, I think links back to one of the other questions about the funding streams. I have a pilot project right now, so I'm very much an early career researcher. But the work that we found for the review paper, were studies that were funded over, decades of research, and often from, national funding sources. So it's definitely possible. I think it seems like it's sometimes a mix of the right people in the right place at the right time with the right idea. But it seems possible, and it seems like there's a growing push to fund this type of research. I do think it's possible, and probably growing in its possibility every day.
Oh, that's awesome. I'm just checking to make sure I haven't missed any questions in the chat. No, I think we're good. I do have a quick question, and it sort of just popped up when you brought up the Healthy Kids program. I believe the last example you gave with the Boy Scouts club. Did you in your review notice any differences in the effectiveness based on socioeconomic status in terms of like food and beverage choices?
Yeah, they didn't really report specifically on that. I wonder if that's either still to come or if they kind of, I don't know if they necessarily assessed that level of detail about the individual participants. I think they probably just have community level, but I'd have to go back and read. I can go back and read the paper and share it with you as well. But it seemed like it was, at least the dissemination was focused on a diverse population of children. So, you know, that's, I think, sometimes a challenge to doing this type of work is that you roll something out wide and you don't always know who gets it and who really benefits from it.
Right. And so I don't see any more questions, but I do want to, thank you, Dr. Mizuka, for this insightful presentation. Very informative on implementation research in community settings, and also for providing us a review of the lessons learned for conducting these equitable interventions in community settings. And so on behalf of the Council on Black Health and the Solutions to Diabetes in Black Americans Core, I would also like to thank our attendees for participating in today's webinar. We will share an evaluation survey for this webinar to all attendees shortly. Have a wonderful afternoon, everyone.